This is Farah Rahman, one of the infectious disease fellows at Icahn School of Medicine at Mount Sinai in New York. I'm going to give you the third part of my lectures. So I'm going to go over the antiretroviral drug classes, treatment guidelines, and infection prophylaxis in HIV. So these are the classes of our antiretrovirals, what we call ARVs. So the first class is nucleoside reverse transcriptase inhibitors. The second class is non-nucleoside reverse transcriptase inhibitors. Third is protease inhibitors. Fourth is integrase inhibitors. And the last is miscellaneous, and we call them entry inhibitors, and I'll go over that. So I just would like to say that this is a really difficult lecture. There's a lot of new words that you're not going to be used to, a lot of different names, so it can be daunting. Even infectious disease physicians themselves have difficulty with these medications, so I don't expect you to be an expert after just this 20-30 minute lecture. So you might have to listen to it a couple times. I'll try to go slow, but I just don't want you to be bogged down with a lot of the names I will go over. It does take some time to learn these, but this will hopefully be a good introduction for you all. So this is a nice timeline that we have in the United States of approved medications. So FDA, our Food and Drug Administrations, are kind of governing body of approving medications. So this is a timeline of those approved medications in HIV. So in 1981, the first AIDS cases was reported in the United States. And then we have the first medication came up in 1987, zidovudine. And that was an NRTI, which I'll go over. Then in the early 90s, you have some more NRTIs that are developed, like danzanine, stebudine. In 95 to 99, you have development of the protease inhibitors, so PIs. So indinavir in 96, ritonavir also in that same year. Then you have also development of the NNRTIs, or non-nucleoside reverse transcriptase inhibitors. Those came up in the late 90s. Some more development in the early 2000s. One that we maybe use more, it's our FDC back in 2004 was fixed drug combination. So combination in one pill. That was 2000 was the first actually, and then 2004 you had Truvada, which we still use in the United States here for PrEP, if you remember from my first lecture. And then in the later 2000s, so 2005 to 2009, you have development of some of the entry inhibitors, so miscellaneous, which I'll go over, Maraviroc, that was in 2007, and then integrase inhibitors, which is what we use now for recommended treatment, raltegravir in 2007. You had more of the fixed dose combinations in the later 2000s to 2010 to 2014. Complera, Stribild are one pill combination, like combination in one pill. Triumeq back in 2014. And then we have more fixed drug combinations, one pill regimens in 2015, 2016, 2017, and then 2018. We have some other ones that we use, Biktarvy being a popular one, and I will go over that later. So this is just nothing that you need to remember, but just a nice time frame to understand how these drugs develop. So basically the newest class is the integrase inhibitors. That's the newest class that we have. Started off with the NRTIs, the nucleoside reverse transcriptase inhibitors. So I'll go over all of these classes. So we'll first start with the nucleoside reverse transcriptase inhibitors, so we call them NRTIs. So we'll start with the mechanism of action first. So it's the same mechanism of action of the non-nucleoside reverse transcriptase inhibitors and the nucleoside reverse transcriptase inhibitors, basically blocking the conversion of HIV RNA to HIV DNA by blocking the reverse transcriptase. So both of those classes have the same mechanism. So with the NRTIs, so nucleoside reverse transcriptase inhibitors, I'm hoping if I repeat it, you'll remember it. So bear with me. But with the NRTIs, these are the lists that we have. So abacavir, emtricitabine, lamivudine, tenofovir, and zidovudine. So zidovudine, as you recall from the earlier slide, it was the first HIV medication developed, and that came out first in 1987. So basically, NRTIs block reverse transcriptase, which is an enzyme that HIV needs to make copies of itself. So these are, I'll go over each of these. So this is abacavir. So something to note, just kind of learning the language of HIV, is that all of these medications have their own 3-letter or number abbreviation. So abacavir, we have a lot of combination pills, so people like to shorten everything and make things easier to write and prescribe. So abacavir is also called ABC, so it's abbreviated as ABC. So some serious life-threatening side effects with abacavir that us ID fellows are often tested on is a hypersensitivity reaction. So you can get fever, rash, GI symptoms, malaise, shortness of breath. It's also associated with lactic acidosis and liver problems. So a big thing when we have a new patient that comes into our clinic, we want to test them for HLA-B5701. With that test, those patients that are positive are more likely to have a hypersensitivity reaction to abacavir. So it's very important that the first lab test, when a patient comes in to establish care with you, that's something to check, the HLA-B5701, to see if they can get abacavir or not. If there is a history of hypersensitivity, basically it's not recommended to challenge them, just to avoid it if there is that history of hypersensitivity with that patient. There has been some studies, it is controversial, but some studies that show increased risk of myocardial infarction or any heart disease. And then no dosage adjustment and renal insufficiency, but recommended in hepatic insufficiency. It's contraindicated in some of those higher liver diseases. And it does come in combo pills. And these are brand names that we have in the United States. So Epsicom is a combo pill, Triumec is this combo pill, and Trizavir is this combo pill. Basically, all these combo pills have abacavir in them. This is lamivudine. This is another NRTIs, example of an NRTI. Its abbreviation is 3TC. So minimal toxicity. There's been some severe acute exacerbation of hepatitis with patients with Hep B co-infection if it's discontinued because it has some activity against Hep B, and you will want to renally adjust these doses. Tenofovir is a popular one, also called TDF. There's actually 2 different formulations. There's TDF and TAF. So tenofovir disoproxyl fumarate and tenofovir alphenamide. It's tenofovir, just a different formulation. So 2 different types depending on what the formulation is, TDF and TAF, both tenofovir. So TDF, it is associated with renal insufficiency, so like Fanconi syndrome, proximal RTAs, can have decreased bone mineral density, exacerbation of hepatitis if Hep B is co-infected and you abruptly stop the tenofovir, diarrhea and headache, and it is renally adjusted, as you can imagine, so you don't want to use it if you have a patient that has a low creatinine clearance, a decreased kidney function. And then TAF, it has same kind of similar renal bone issues, but less likely and less severe. You can't have that acute hepatitis flare, also diarrhea and headache, and you can use it, but not recommended for creatinine clearance less than 30. And zidovudine, this was the first one, so it's actually still used to prevent mother-to-child transmission in the United States. So it's it is given during pregnancy and childbirth to the mother, and given to the infant for 6 weeks. It does cause bone marrow suppression. I have seen this. in patients. So macrocytic anemia, neutropenia, also kind of the typical nausea, vomiting, and headache. You can get nil pigmentation, liver problems, hyperlipidemia, insulin resistance, lipoatrophy. These are, fat wasting in certain parts of your body, myopathy, and this is again also renally adjusted. So moving on to the next class is the non-nucleoside reverse transcriptase inhibitor. So this is NNRTIs. So it's a second class. We had the NRTIs first, and now we have the NNRTIs. Okay, so again, it's the same mechanism that we saw with the NRTI. So you're blocking the conversion of HIV RNA to HIV DNA by blocking the reverse transcriptase. And so these are examples of some NNRTIs. So NNRTIs, like I said, bind to and later alter reverse transcriptase, which is the enzyme that HIV needs to make copies of itself. So again, this is the list of the NNRTIs, and you can see that three character abbreviation that follows it. So efavirenz, also called EFV, etroviral, which is ETR, and nevirapine, NVP, and molpivirine, which is RPV. So I will go through these. So efavirenz, also EFV. So it's can be associated with rash. So these are some side effects that you can see. So rash, neuropsychiatric symptoms, elevated LFTs, hyperlipidemia, QTC prolongation on your ECGs. You can take it on an empty stomach, has a pretty long half-life, and it's in the combo pill called Atripla. Something important to remember with efavirenz is that they like to test is the neuropsychiatric symptoms. So patients that come in with kind of crazy dreams, it's a common side effect of efavirenz. So something to remember because they like to test on that. Etroviral, also called ETR, you can get rash. SJS is Stevens-Johnson syndrome. Also hypersensitivity. You want to take it after a meal and it's not renally adjusted. Nevirapine and PV also can be associated with rash and SGS, Stevens-Johnson syndrome. Symptomatic hepatitis, including fatal hepatic necrosis, can happen, and there's a rash in 50% of those cases. And interestingly enough, it's common in females that have not been exposed to antiretroviral, so ARV naive females with a CD4 count greater than 250, and then in ARV naive males with a CD4 count greater than 400. So those you do not want to initiate nevirapine because there's this more, they are more susceptible to this side effect. You don't renally adjust it, and it is contraindicated in liver disease. Rilpivirine, RPV, also rash is common, so it's a common. You can see this pattern in NNRTIs. So rash, depression, insomnia, headache, hepatotoxicity, also QTC prolongation on your ECG, and it's in combo pills like Complera and Odefsey. Okay, so I know that was a lot. We're kind of halfway there. Just digest it for now. And, again, a lot of this comes with repetition. So I'm going to move on to the next class, and this is protease inhibitors. We also call this PIs. So the mechanism of action for protease inhibitors, so it blocks new HIV from becoming mature HIV. So it's blocking the protease enzyme. And so here are some examples of protease inhibitors. So atazanavir, ATV is the three-letter abbreviation, darunavir, DRV. And the thing with the protease inhibitors, they have to be boosted. It's something that they need a booster. So cobicistat, or we call COBI, is a booster, and you have to put a booster in with the PIs. And those are the combo pills. So you need atazanavir with cobicistat. You need darunavir with cobicistat. So it's a combo pill. There's some other ones here, but the bolden ones are the ones that are recommended in the guidelines. So the first two ones, if you are going to use a protease inhibitor, you would want to use atazanavir boosted or darunavir boosted. And so some advantages, it's a high barrier to resistance when you're using the boosted PI. And it's okay to use if you have kidney issues, and it's actually safe in pregnancy. But the drawbacks is it does require a booster. So booster, it's boosting the medication. So if it's boosting the PI, it's going to boost other drugs that patients take. So it increases levels of other drugs. So there's a big issue of drug-drug interaction. And then, I make a comment that especially in our transplant patients, they're on so many medications and so many immunosuppressant that it is really difficult for our transplant patients to be on protease inhibitors. So those are kind of the biggest drawbacks. We can also have metabolic effects. So dyslipidemia, hyperglycemia, insulin issues, and lipodystrophy. So these are just like fat, fat redistribution. So if you have like a buffalo hump, that's considered like a lipodystrophy. You can also have cardiac conduction effects, increased risk of bleeding, actually in patients with hemophilia. And there's actually only one single pill option, Simtuza, which was approved pretty recently. So basically a lot of pills and a lot of drug interactions with protease inhibitors. So to go into each of them a little bit deeper, so darunavir, it's a protease inhibitors. It's pretty strong, potent. It's a later generation protease inhibitor. You can combine it with a booster, so ritonavir, it could be Cystatin. High barrier to development of resistance, retains activity with other PI resistance. You don't need to adjust for any kidney issues. And it's actually one of the preferred PIs in pregnancy, and you want to dose it twice a day. Some of the disadvantages with darunavir has some moderate GI side effects. You want to give it with food. It's a sulfa moiety, so there's a potential for allergy with the darunavir. So if you have a patient with a sulfa drug allergy, you would probably want to avoid darunavir. So rash is 10% incidence. It's usually mild to moderate, but there is a very rare chance of getting Stevens-Johnson syndrome and history of sulfa allergy. Not a complete contraindication. And, of course, you need to boost it. You need a booster, and that comes with drug interactions. Atazanavir, it was previously a pretty popular PI, but now it's second line since darunavir is now on the market. It may have a less activity on cardiac conduction than other PIs, and it also can be used in pregnancy. Some of the disadvantages, so the biggest side effects are hypocholesterolemia, indirect hyperbilirubinemia, renal stones, and it's an acid-suppressing medication will reduce absorption. So with these patients, if they have like acid reflux and you want to give them a PPI, so something to help with their acid reflux, you wouldn't want to do it on patients that have who are taking atazanavir because it will reduce the absorption. The anti-acid that you would give them would reduce the absorption for atazanavir. So this is a common thing, at least infectious disease fellows are tested on, but atazanavir can cause hyperbilirubinemia. So it inhibits UGT, which is the enzyme that conjugates bilirubin. So it makes bilirubin into conjugated bilirubin. Indinavir also has the same effect. So basically something to remember, atazanavir can cause hyperbilirubinemia. Okay, so the last class and the most important class, because we use integrase inhibitors a lot, are integrase inhibitors. So I will go for this is the mechanism of action for integrase inhibitors. So blocks the insertion of HIV DNA into the CD4 cell DNA. So it blocks integrase and it's stopping that mechanism. And so these are some of the ones that we use. Raltegravir, also RAL is the abbreviation, Elvitegravir, EVG, dolutegravir, DTG, and bictegravir, we call BIC. Ones that I want you to remember are bictegravir and dolutegravir. Those are the common ones that we use in practice. So some of the advantages, it's well tolerated, not a lot of side effects, not a lot of medication interactions like the PIs do. There's a high barrier to resistance. So the later generations, the the risk of resistance is low when you're using this class. It's can be given with a decreased renal function as well, a reduced GFR. Some disadvantages, some of these studies are still coming out and, we're not 100% sure on them, but there's this question, is it safe in pregnancy? It was associated, some of the integrase inhibitors were associated with neural tube defects for women that were taking it and they birthed their child. So those children, there were some that were born with neural tube defects. So there's this question if it's safe in pregnancy to use. There's some question about neuropsychiatric effects. There's some question about weight gain. And then it is the more expensive class. So those are some disadvantages. A lot of these studies are ongoing and data is coming out, but these are the things that have been kind of put out there right now in the literature. So raltegravir, it was the first approved integrase inhibitor. So that was in 2007, if you remember from the timeline. So it's now, of course, considered a first generation integrase inhibitor. It was thought to be safe in pregnancy. Some of the disadvantages, it has a lower barrier to resistance to some of the other integrase inhibitors. A failure of raltegravir to be resistant often confers resistance to other integrase inhibitors. So you have to dose it twice a day. And some of the side effects are rhabdomyolysis or myositis. Elbaitegravir is another first generation integrase inhibitor. It can also, if you fail with elbaitegravir, it can confer resistance to raltegravir and also maybe confer resistance to dolutegravir. It can require a booster as well. It does require a booster, so you have more drug interactions. So the C is the cobicistat. You need to take it with food, and there's not right now enough data to recommend it in pregnancy. So dolutegravir is a second generation integrase inhibitor. So advantages, it's very strong, high potency, it's high barrier to resistance, minimal side effects, and you can take it with or without food. Some of the drawbacks, it can inhibit tubular secretion of creatinine. So you can increase your creatinine like a mean of 0.11. Milligrams per deciliter. There's some questionable psych side effects, some mild GI side effects. It can absorption may be affected by polyvalent cation, so it can take at least 2 hours before or 6 hours after a cation containing antacids or laxative. So the absorption of dolutegravir is reliant on that. So you want to be cautious if your patient is taking an antacid or a laxative to time it appropriately with their HIV medication if it includes dolutegravir. And like I mentioned, there's some studies out there that dolutegravir was associated with a neural tube defect. So there's a pregnancy warning. But again, it's the data is still coming out and it's still like not completely clear. And then bictegravir is the newest integrase inhibitor. It was approved February 2018. And it's only actually available in a combination pill. So you can't prescribe bictegravir on its own. It comes in this pill called Biktarvy. So that has Biktarvy, tenofovir, and emtricitabine. It's a smaller pill. It's pretty small. It's a high barrier to resistance. And again, it's similar structure to dolutegravir. So that issue of the neural tube defects when used in pregnancy that question is still out there, but again, the data is not completely solid on that. But these are some ones that I want you to remember is bictegravir and dolutegravir. So Biktarvy, I really often prescribe in the clinic. It's pretty well tolerated. And so these are some miscellaneous medications, so they don't really have a class. So I really don't want you to focus on these ones. These are kind of above, levels of medical students. It's what we have to use in the infectious disease world. So we only really go to this class if patients have failed other regimens and have shown resistance to the other classes. So we rarely go to these medications unless there's no other option. So just something that for you to be aware of, that these medications are out there. So Maraviroc in 2003, and Furatide, which was in 2007, and Imiluzumab, which was in 2018. So Maraviroc, just quickly, it's an entry inhibitor that binds to the CCR5 receptor, if you remember from my first lecture. It acts by blocking or inhibiting a host protein or receptor rather than the viral target. So it's like the only kind of entry inhibitor. And it's, again, like I mentioned, what we call salvage therapy. It's reserved for salvage therapy, so patients that have failed all the other classes. And Furatide, also called Fusion, it's also known as T20. It's a fusion inhibitor, again, limited to salvage therapy. So patients that have had extensive treatment history, multi-class antiviral, retroviral resistance, and just few therapy options. And then Imiluzumab, so this is actually an IV. It's not a pill. It's an IV. Monoclonal IgG4 antibody prevents HIV cell entry by binding to the domain 2 region of the CD4 receptor. Again, reserved for those patients that have had a lot of resistance. So that was a lot of new language. Basically, I was trying to teach you a new language in the last 20 minutes or so. So I know that's a lot. But the thing that is important to remember is treatment and what the current recommendations are, and what patients should be on. So we know that patients should be on 3 drugs, three HIV medications. You can't just do one. You can't just be on tenofovir. You can't just be on a PI or one integrase inhibitors. You need 3, and we call a backbone, and you need something else. So what the recommendation right now is, so the backbone is 2 NRTIs. So that's what we call the backbone, and then you need to add another medication. So what the current recommendation is using an integrase inhibitor. So you want to use your 2 NRTIs, that's your backbone, plus your integrase inhibitors. And that's what we've been, that's the current recommendation, and that's what we've been giving and prescribing our patients. So that's why I wanted you to focus on bictegravir and dolutegravir, because those are the very common integrase inhibitors that we've been prescribing recently. And then you want to make sure to give those patients not only bictegravir or dolutegravir, but give them the 2 NRTIs, so like tenofovir and emtricitabine you could do. So that's the first one. So BICTAF-FTC, that's a Biktarvy, tenofovir, and emtricitabine. So tenofovir and emtricitabine are the 2 NRTIs. Bictegravir is the integrase inhibitor. So again, 3 different types of medication. That second bullet right here, so you have dolutegravir, that's the integrase inhibitor, and then you have abacavir, and then you have lamivudine. These are the 2 NRTIs. So these are the very common medications that we prescribe. And if you remember early in the lecture, abacavir, you want to make sure that their HLA B5701 is negative, because you want to avoid that hypersensitivity reaction. So very important. This is kind of the money slide. And there's other regimens that you can that in certain clinical situations, but I think for the scope of this lecture and for your knowledge base right now, this is where I would this is what I would remember. But please reference the slide to kind of go over the regimens. So prophylaxis is also very important in our patients. So if you remember from my lecture, my second lecture, I talked about some of the opportunistic infections that our HIV and AIDS patients are susceptible to, specifically with their CD4 count. So it's important to put them on prophylaxis. So I'm not going to belabor this too much, but this is a very nice slide. So if you recall from my last lecture, so pneumocystis jirovecii, also PCP, the indication is when the CD4 count is less than 200, and you want to give them trimethoprim sulfamethoxazole. So that's the preferred prophylaxis. toxoplasmosis, that's what you want to start the medication when the CD4 count is less than 100. But it's the same. It's the same prophylaxis, trimethoprim sulfamethoxazole. So we abbreviate this as TMP-SMX. MAC, Mycobacterium avium complex, CD4 less than 50, you can do azithromycin. And then latent TB, you want to do INH, isoniazid, and do that for 9 months. So this is a very nice slide just to remember prophylaxis for these patients. And again, it's the indication, it's always by the CD4 count. So less than 200 is your marker of when you want to kind of start to think about or do put your patients on prophylaxis medication. So I will end the lecture with one question. So we'll read this question together. So we have a 28-year-old woman is evaluated following a generalized erythematous rash that developed 1 week ago. The rash is now resolved. She reports no additional symptoms. She was diagnosed with HIV infection and AIDS and was also diagnosed with pneumocystis jirovecii pneumonia. Her CD4 count is 99 and her viral load is 31,000. Along with starting her antiretroviral medication, what additional medication would you start? So again, I'm asking for prophylaxis, and with prophylaxis, the biggest thing to remember is their CD4 count. So I am going to go to the next slide, and if you want to pause and try to answer the question, you can, but the answer to this question is B, trimethoprim sulfamethoxazole. So basically, this patient, she was diagnosed with pneumocystis jirovecii. Her CD4 count is less than 200. It's 99. So you want to put her on trimethoprim sulfamethoxazole. Also, you are prophylaxing her against toxoplasmosis, right? Because with toxoplasmosis, we would prophylax when the CD4 count is less than 100. So she meets both the criteria for pneumocystis jirovecii prophylaxis as well as toxoplasmosis prophylaxis. So this is the end of my lecture. These are my references. Again, this was a lot of information, and it takes a while, so I don't want you to be discouraged if this was a lot. It definitely takes some time, but I hope this was a nice introduction for you, and thank you for listening.